Dr. Sonia Arora Ballal is a pediatric gastroenterologist at the Boston Children's Hospital and instructor in pediatrics at Harvard Medical School. She completed her pediatric gastroenterology, hepatology, and nutrition fellowship at Boston Children's Hospital, Harvard Medical School, and her pediatric residency at the Johns Hopkins Hospital in Baltimore, Maryland. She is a graduate of the 7-year integrated BA MD program at the George Washington University, where she majored in religious studies. Currently, she specializes in comprehensive gastroenterology with a focus on children with autism and gastrointestinal problems. She is also the Associate Director of the Fecal Microbiota Therapeutic Program and a co-director of the Cornelia de Lange Clinic. Dr. Ballal is a passionate teacher and mentor with particular emphasis on promoting thoughtfulness and inclusivity around health equity. And we are so fortunate that she will share her passion to educate others with her well-researched, comprehensive presentation, Treating Children with Autism and Gastrointestinal Problems.
Hello, thanks for joining me. My name is Sonia Ballal, and I'm going to be speaking with you about one of my favorite topics, which is treating children with autism who also happen to have gastrointestinal problems. First of all, I'm going to start with a very brief slide to introduce us all and put us on the same page about what is autism. Autism spectrum disorders are as varied as the children who are diagnosed with them. They are complex disorders of brain development, and there is a huge spectrum of clinical diversity. The diagnosis often relies on clinical symptoms. It is important to think about sensory perceptual differences, as this is really important in thinking about how children will interpret symptoms, how parents might observe symptoms. Some kids are hyper or hypo-reactive to sensory stimuli. Sometimes they may have fragmented or distorted perceptions of stimuli, or even a delayed perception. Sometimes parents will describe them as having a very high tolerance to pain. Sometimes sensory overload is just too much, and it just seems like they can't even process enough to share with us what's going on. This can also impact their perception of prompts from their body and with symptoms and how they're feeling themselves. Even though that is a very brief intro into the definition of autism, I'm actually going to be spending some time today focusing on some of the comorbidities that we see in children with autism. And certainly there are neurologic and psychiatric diagnoses that are frequently made, but I'm going to be focusing on really my area of expertise, which is thinking about GI symptoms, gastrointestinal symptoms in children with autism. GI issues in kids who happen to have autism can be varied. They can be as simple or straightforward as constipation, which is not always as simple when it comes to treating it. Diarrhea, reflux, burping, vomiting, flatulence, common symptoms that we can see that impact their GI tract. They can also present in less typical ways with nighttime awakening, maybe an increase in self-injurious behavior. We see issues with some children who just don't grow well and have poor or slow weight gain, and then issues with other children where it's the opposite and we're dealing with obesity. Sometimes we can worry about abdominal pain presenting in typical and atypical ways, inflammatory bowel disease as well as irritable bowel syndrome, food allergies. So as you can see, children with autism are vulnerable to just as many GI issues as any other children. And this link between children with autism having GI issues is not just something that families have noted anecdotally. It's actually been studied scientifically, and there's quite a bit of literature that supports this connection. One of my favorite studies, one that I would like to share with you today, is a 2014 study that actually analyzed a whole bunch of smaller studies and pulled them together to say, is there really a connection between autism and GI issues or GI problems? In this study, this was a meta-analysis looking at 15 separate studies and over 2,000 children who were diagnosed with autism, and then determining what types of GI symptoms might be occurring in those kids. What our authors concluded is that having a diagnosis of autism made you more likely to have a GI issue. In fact, a child with autism is 4 times more likely to have a GI issue. This is really important in thinking about, from a clinical perspective, what our families might be dealing with. And just having a diagnosis of autism might make you more likely to suffer from certain GI complaints. So, from my own perspective, as a gastroenterologist who often sees children with autism, I start to think about how are these issues actually translating to my patients. So I'm going to actually explore 2 separate questions with you today. One, how do we optimize the outpatient experience for these children and their families? We understand that there are certain specific aspects to having autism that might impact the clinical visit, the ambulatory visit. How do we optimize that experience? And 2, what is the role of endoscopy in caring for children with autism? Endoscopy is a type of diagnostic and therapeutic modality which is really specific to gastroenterologists. So let's start with that first question. In my own GI autism clinic, it is very clear that there are communication challenges. Children with autism frequently have GI symptoms and diagnoses, as we just discussed, and children with autism may also have communication challenges. This is not a new problem. There are some solutions that others have trialed with varying degrees of success. Augmentative or alternative communication devices have been shown to increase expressive and receptive language in other settings, including home and in school. And these type of devices have also been shown to increase patient satisfaction in adults who use them who are seeing primary care. However, what about children with autism? There's really limited research investigating the feasibility of communication tools in the pediatric ambulatory subspecialty setting. So we decided to take this challenge on, and we wondered, could we actually design and use communication tools in an outpatient GI clinic? Our hypothesis was that the use of such tools would not only be feasible and acceptable, but they would actually enhance clinical encounters from a patient-family perspective, but also from the clinical perspective, from the clinician who is actually participating in that visit. So in order to do this, we first had to find some speech pathologists who are interested in this topic and help us create GI-specific augmentative communication tools. Then we conducted some research where we administered a series of surveys to patient families and physicians before and after use of these tools. We also assessed these patient interactions with the help of our speech pathologists with video recordings of the visits. So let's start by thinking about these visual task lists. And for many of you who may be familiar with this type of a tool, it is frequently a type of tool that's used for children with autism, sometimes at home, sometimes at school, but not so far in an outpatient GI setting. So we needed to create our own. We worked with speech pathologists and recreated a visit where we would take pictures of each aspect of the visit to create a visual task list that would lead us specifically through the kinds of visits we conduct. Some of these things are as specific as an abdominal exam. Of course, that would happen in a GI visit. But even for children who may have a gastrostomy tube or a nasogastric tube, we have visual task list cards that are applicable for those patients as well. So what about our patients? Our inclusion criteria were children with autism who were in a GI clinic coming in for a visit between the ages of 3 and 21, for whom speech does not meet functional communication needs. We intentionally recruited patients, at least a third, who are non-white, and we excluded children with autism for whom speech meets functional communication needs. I want to go back to one of those inclusion criteria for just a moment because I think this is a really important point. This is a really critical study that looked at over 3,600 children with autism to see what type of subspecialty services they accessed. And what this study found is that children with autism who are non-white were less likely to access subspecialty care. The most striking differences were in use of gastroenterology and nutrition services. So with this type of research in the back of our minds, we really wanted to be intentional in recruiting at least a third of our patients who are non-white, acknowledging that we may not have done such a good job in reaching non-white populations in the past. What did we find out when we did this study? Well, those visual task lists, those pictures I just showed you a few minutes ago, seem to increase patient engagement and satisfaction. We saw that patients do use clinical communication tools in non-clinical settings, just as we described earlier that is a possibility, but they're not really using them in medical visits. We also saw that most of the time, parents felt that patients do not typically participate in visits. We were also able to conclude that communication tools are not only helpful and desired by parents, but something that they really want and would love to have more of, even in a non-traditional place like a subspecialty clinical visit. We also saw that these tools seem to increase patient comfort, understanding, and participation. So this graph here is really interesting. All the columns in blue are before the visit. All the columns in orange are after the visit. And parents felt that their child felt more comfortable, their child had more understanding, and they had more participation after the visit with a visual task list as compared to prior to the visit without the visual task list. What about from the physician perspective? One of the things we worry about quite a bit on the physician end is using an extra tool, doing an extra thing. How will that impact the flow of our day? Will it take away from our ability to maybe give to another patient? And so we've got to spread ourselves evenly throughout the day. Will this type of a tool actually make our visit longer? What we found was that physicians who were surveyed felt that the tool used was helpful, and 100% would like to use the tool again. Only in one situation was it found that that tool seemed to prolong the visit. Some of the quotes that the physician shared with us were that they actually felt that the child was more comfortable with the physical exam by having the visual task list, that there was better behavior, the child seemed more calm. And another physician noted that having a visual task list gave a structure to the visit and actually might have made it even more efficient because everyone was on the same page about what was coming next. So in summary to this portion, GI communication tools, when used in a busy subspecialty outpatient practice, can improve the clinic experience for patients and patient families. They can also increase engagement after our speech pathologists observed some of these interactions with video recordings. Additionally, these communication tools can improve the clinic experience for physicians without necessarily compromising time. So this could be something that could really be incorporated into the workflow of a busy clinic. So we've talked a little bit about the clinical visit, but let's talk about GI procedures. So this is a schematic here of a cartoon individual having an upper endoscopy. And an upper endoscopy is a procedure that's specific to gastroenterology, where we have a long flexible camera that's got a light at the end of it. While a patient is under anesthesia, that camera is inserted into the mouth, then down the throat or esophagus, into the stomach, and into the first part of the small intestine. And just like going down a garden hose, we are able to see in a circular fashion all the way through those parts of the GI tract. In this picture here, you can see the anatomy of that GI tract that we take a look at, and a circular picture of what looks to be an esophagus. Our question, specific to the patient population we're talking about today, is that do children with autism have abnormal findings on endoscopy? And the purpose of our study was to examine multiple clinical characteristics and findings on upper endoscopy for children with autism. And we wanted to compare these results to other control groups, specifically two control groups. One control group that had developmental delay and another control group that was labeled as typical development. We wanted to match according to age and sex. Our hypothesis was that the rates of abnormal findings on endoscopic evaluation would be slightly increased in children with autism compared to both control populations. But to be honest, we weren't sure what we were going to find. This is sort of part of the beauty of this study. So this is a very busy slide, but I think what I really want you to focus on here is the fact that we used a variety of methods to look for these patients. We started with a large period of time where we assessed medical records of 17,000 patients, over 17,000 patients. And we determined, first of all, how many of those patients had a diagnosis of autism. We excluded patients who may have had another procedure on the same day or may have had comorbidities of cardiac disease or respiratory disease, knowing that that might complicate some of the findings we may be looking for, potentially confounding the results. We then took that group of patients who had autism and matched them by age and sex to children who had upper endoscopies during the same period but had a diagnosis of developmental delay, not autism. We then took that same pool of patients and looked for age and sex matched controls of children who had an upper endoscopy who had neither diagnoses of autism nor developmental delay. That's our second control group. And we matched that 1 to 2. So at the end of all of this, we ended up with quite a large database of 2,000 patients, 500 plus with autism, 500 plus with developmental delay, and over 1,000 who are labeled as typical development. We then scoured each of these 2,000 patient charts to determine endoscopic and histologic findings. And I want to pause for a moment to just share what that means. Endoscopic finding means the picture I showed you on the previous slide, where we're actually looking in an endoscope, and what is it that we see? Histologic findings mean that we take tiny little biopsies at the time of the endoscopy, we share them with our colleagues in pathology, and we look at them under a microscope. So we're talking about the cellular level. That's the histologic finding. As you can see, patient demographics and clinical characteristics for individuals according to developmental status is shared here in this graph. And there are a couple of things I want to point out because, again, this is quite a busy but important piece of information to have going into and thinking about this study. First of all, I mentioned to you that we were studying children with autism, and we have 2 control groups. So they are age and gender matched. And you can see that age and gender is very similar in all 3 groups. So we were able to achieve that matching quite well. Secondly, we were looking at a background of these individuals, and you can see we have similar percentages when it comes to racial and ethnic differences across these 3 groups. Third, we talked about medications between these groups. We could see some differences. Children with autism were more likely to have anti-seizure medicines, similar to children with developmental delay. Not always the case in children who are typically developing. We then looked at GI disease and why are they having the endoscopy in the first place. What about our results? What did we actually find? What were the endoscopic findings as noted by developmental status? So on the left here, I have a cartoon, super rough, of an upper GI tract. And I wanted to share this with you because this is exactly what I draw out for every single patient that I am doing a procedure on when I'm obtaining consent. I draw out the esophagus, the stomach, and the small intestine. So I did it for you today. And then this is how I think it's best to think about the results of this study. When we looked at the esophagus, we could see that children with autism, as compared to those with developmental delay and typically developing, to the endoscopic eye, seem to have similar rates of findings, okay? Same in the stomach and same in the small intestine. So we're talking about generally similar rates between all 3 groups in these 3 portions of the GI tract that we look at with an upper endoscopy. But then there's that second level that I mentioned earlier, the histologic level, or the part that we look at under a microscope. So what happens when we look at those biopsies under a microscope? Well, here we saw some differences. For children with autism, In the green box labeled here, we saw higher rates of esophagitis, or inflammation in the esophagus or in the throat. We saw similar rates of abnormal findings in the stomach in all three groups. And in the duodenum, or the small intestine, which I'll share on this slide here, we actually saw fewer rates, lower rates of abnormal findings in the group of children with autism as compared to the other two. So this made us pause, and it made us wonder a little bit, to think a little bit more deeply about this. What do we know so far from this study? First, as I mentioned earlier, it's a large study, 2,000 children. We have well-matched control groups. So this helps us think more deeply about the findings we might have because we have robust control groups. What we were able to see is that children with autism have abnormal findings in all parts of the GI tract assessed with the upper endoscopy. And this is important because we really hadn't been able to prove this with such a large database up until now. Next, children with autism seem to have higher rates of abnormal findings in the esophagus, yet lower rates of abnormal findings in the duodenum when compared to these control groups. So our next question was, could a diagnosis of autism actually help us predict abnormal findings in the esophagus? And how would we determine that? So this again is a bit of a busy slide, but an important one because we worked with our colleagues on the statistical end to really question this. And we did this forest plot is showing a univariate analysis on the left and a multivariate analysis on the right. And we wanted to look at different factors, different predictors of these abnormal findings. And what I'm sharing with you is a forest plot looking at abnormal findings in the esophagus. And when you're doing a univariate or a multivariate analysis, you peel away the different things that might be influencing the results that we're seeing. And when we did this, we were able to see and conclude that having autism is actually an independent predictor of abnormal findings in the esophagus. You are 1.4 times more likely, the odds ratio is 1.4, you're 1.43. You're 1.4 times more likely to have abnormal findings in the esophagus simply by also having autism, based on the study population that I've just described to you. We did the same type of an analysis in the duodenum, in the small intestine, and we found that having autism, when we did this type of analysis, did not necessarily protect against abnormal findings in the duodenum. So there's something about the esophagus that seems a little bit different. So what do these results actually mean? One, children with autism actually do have abnormal findings on endoscopy like we suggested before, and that children with autism seem to have higher rates of esophagitis as compared to children with developmental delay and typical development. Not only are these rates higher, but when we do univariate and multivariate analyses, we see that autism pops up as an independent predictor of abnormal findings in the esophagus. So this is a lot of biostats talk. What do we take from this? Should all children with autism have an upper endoscopy? Should they all be seeing a gastroenterologist? Speaking as a gastroenterologist, I would say no. However, children with autism who present with GI symptoms or atypical symptoms that parents, caregivers, primary care physicians may be intimately aware of should be seen by their primary care doctors first, potentially referred to a gastroenterologist for a really nuanced discussion about all of these risk factors, some of which we've described and some of which would be elucidated during the visit, to have a really comprehensive discussion about whether or not further evaluation is needed, and that may include an endoscopy. So some key takeaways in thinking about what we've discussed today. GI issues can occur frequently in children with autism. We can tailor communication devices and tailoring communication itself to improve the clinic experience for patients, patient families, and for physicians. Children with autism can have abnormal findings in the GI tract, as we just discovered when we looked at a very large database and upper endoscopy findings. And this can occur even with atypical symptoms. If you are worried about GI issues, discuss these concerns with a primary care physician and consider referral to a gastroenterologist. Thanks for your time.
Sonia, thank you so much for this talk. This is going to take me a while to unpack because it is so much information. I wish I had another
There's a lot of
suitcase.
information. Yes. Yeah.
And it really is more than 2 talks in one. It's really 3 talks kind of talking about the general presentation as well as these issues with communication in the clinic and the endoscopic findings. So I want to talk about the communication part first. Obviously, you learned a lot with going through this process and establishing this. And I know that a lot of families already sort of work through what it's going to be like with kids before they even come to the clinic. In a way, this map that you've put together is like a social story. But is there something that we should be doing in terms of a social story even before these kids walk into our clinics? And then this is such a nice preparation for them to know what's coming.
Absolutely. Well, first, thank you for having me. It's been fun to share all of this. I will say that you are correct. I think that there are multiple types of augmentative communication devices that could be really useful. And what I didn't have an opportunity to share with you is that we thought about those other devices too, or those other modalities. We actually created some social stories for kids to use in advance, and we didn't study those as much, but we've just incorporated those in as part of our go-to, so that kids know what to expect in advance, and parents can review that at home. We also thought about communication boards, which can be specific to many of the augmentative communication devices that kids are using, such as iPads in school and with therapy sessions. And we found that they liked the simplicity of the visual task lists best. And so that's why I chose to share that data with you today. But there seemed to be something about the physical movement of each card from one side to the other as you're going through the visit that was really appealing and very easy to conceptualize. To be honest, for physicians and parents, as well as for kids, it just gave a really nice direction to the visit. And so there's something to be said about these simple tools. And we know they work in other settings. We know that they even work in certain primary care settings. We just haven't really studied them in gastroenterology. And instead of using a generic version of this, why not create something that's really specific for what we're doing every day so that kids can feel like what's actually happening is mirrored in those visual task lists?
And I have to say, having been one of the providers to be a part of the participation with these kids, it didn't slow me down.
Great.
And it really did seem to make that child more participatory in the process. I've just examined your tummy. Let's move that over. And that task is done.
Yes.
And we're going to do these things. It really helped get those kids through the process.
Yes. Some of my favorite moments were things when, a kid would jump up onto the table, like, I'm done listening to you. I'm ready for the exam, because that's what's happening next. So it created a strange sort of efficiency in some ways. And I think it just gave everyone an outline of the visit in a really clear way, and in a way that I think could make sense for some of these kids. Now, no shoe fits everyone, and certainly this visual task list may not work for all children who happen to have autism and GI problems, but it was really nice to see it resonate with so many.
Do you think it's more effective for those kids who don't have the language or who are lower functioning in that regard because you can talk other kids through? Or is that something we don't know yet?
I'm going to say it's something we don't completely know yet. Certainly, we did target kids who may have lower language sort of capacity or abilities at the time of the visit. And so therefore, we were really looking at those kids. But what I also noticed is sometimes it would still be up in a room, and I would do another visit with a kid who may not have autism but might have anxiety. And they found those visual task lists really reassuring as well, because it really helped them know this is what's happening next, no surprises. And I think that piece of it was intriguing to me, to think about how something like this might just be a good thing to start incorporating into our visits in general. So definitely other groups could benefit from this too.
Yes. So I want to change topics because you did and talk about the endoscopy paper and the like. I don't think people understand what a monumental process you went through to obtain this much data about this many kids. This is a gigantic group of individuals that had to be looked at and have all of those data pieces sorted through. One of the questions I had in terms of esophagitis, families will ask, and I know you cover it in the paper, there is esophagitis, and some people know about this condition of allergic esophagitis or eosinophilic esophagitis, and that's usually defined as a difference in what you see with the histology, with the biopsies. Often there are visual changes in those guys too. Mm-hmm. You had findings particularly about eosinophilic esophagitis. Can you touch on that?
Yes, we definitely saw rates of eosinophilic esophagitis being slightly higher, but what was really driving our findings, at least in this cohort of individuals, was higher rates of neutrophilic esophagitis, or the type of cell that we can see sometimes with reflux or some type of an acute injury. And that doesn't mean that eosinophils aren't playing a role. I think that's still a question we have left to answer. But in this particular set of patients, it seemed like it was driven more by acute neutrophilic esophagitis.
When you did the multivariate analysis looking at the differences between these groups,
yes,
would that have fixed the question of referral bias? So one of the questions that comes up is, oh, you guys are at Children's and people are coming to see you because you're an autism center and you see kids with GI issues and autism, and therefore your numbers are probably skewed high. I actually wondered if the reverse could be true in our population, because we are also a center that sees a large number of kids who have eosinophilic or allergic esophagitis and who are referred specifically because they've got blood work that says they've got celiac disease and they're going to have celiac when we go do their duodenal biopsies. Is it possible that those referral issues could mess up our explanation of why we saw a higher frequency of esophagitis in this population?
Sure. I think that's a really good point, and we always have to think about referral bias. But I will also say this is the benefit of having the control groups, because we are comparing these children with autism to other children who are seen at Boston Children's, part of the same referral bias, who happen to have developmental delay, other children who have neither autism nor developmental delay, so therefore we categorize them as typically developing in our study. And they're the same referral center. So we're comparing these groups to each other. So there may be a referral bias for all three groups combined, but because the results that we're describing are comparing the groups to each other, I actually think we take away a little bit of that referral bias with those control groups.
I think that's very helpful.
Okay.
And I think the other thing that is going to be interesting over time is that we learned that we have such a good population to do these evaluations
Absolutely.
on that we should be able to make these same kind of judgments in lower GI endoscopy or other evaluations that we do on this population.
Absolutely. I think this really, to me, in some ways brings up even more questions. Do we want to look at esophagitis specifically in children with autism? Do we want to think about maybe more prospective studies around this? What about use of medications, which I just started to talk about but didn't get into a lot of detail on during our discussion earlier? Do we want to think about different types of acid blocking medicines and how those may or may not be playing a role here? So there are lots more questions that have come from this study, at least for me.
Well, thank you for spending the time and spending the time on the research and spending the time on putting this presentation.
Thanks for your help with it
together.
too. Thanks for being a partner in it.